Doctor, we can start the lecture now. Doctor, turn on the mic, please.
Okay.
Okay.
Is the camera open?
Yeah.
Okay, I don't see it.
We can't see you, doctor. Don't worry.
Okay, then. Good afternoon, everybody. I am Elpis Tsintsifa from Greece, and tonight we're going to be talking about our feet and the ankle joint. I do love this subject. This is something that I've been working for some years because I had this experience since I was very young to find out how important it was to take care of my feet for myself. So when I had the chance to work with patients, to work with clients, and give them the benefit of starting from their feet, it's my goal to give them the same input. So let's see if I can manage. Okay, we used to think that this is the ultimate symbol of a strong and healthy body. And maybe we need to reconsider that. In my opinion, this is how we should be looking at abdominals and six-pack. And this is a concept we're going to discuss about. So we're going to be looking a little bit about anatomy and kinesiology, then the role of the foot in the posture and the functional capacity, the basic functional movements and some assessments, the most common injuries of the foot and the ankle. And the truth is, I would like to focus more on this last part, the exercises for rehabilitation and programming regarding injury prevention, not just rehabilitation. So 1/4 of all our bones are located in the foot and they're connected to each other with joints. And we do have 33 joints, all of which should be able to move independently of each other to some degree. We have all seen people that didn't have the chance to use their hands to be able to do really magic things with their feet. And that shows that there are ways that we can improve our feet, even if all we need to do is make them function and without any pain. So starting from the back of the foot, we have two large bones, the calcaneus and the talus. The talus connected to the fibia and the tibula. There it is. Right. No, Nala, I cannot see my picture. Can you help me in that? Because it's hard for me to talk without knowing where you guys see me. Can you help me with that?
Help you with
Okay, and I think I got this. I cannot pin it. Okay. I am sorry. I need to. Okay. Okay. I think now we can see. I can, guys, I can hear some. Can we mute? Nala?
doctor.
Can you see me?
Yeah, I can.
Okay, I cannot see anybody. All right, okay, I go back, that's fine. I'm sorry if I might be looking different directions, but I don't see you guys. Okay, this is the foot. I don't know if you can see it. So this is the calcaneus and this is the talus. And as we're going towards the mid of the foot, we have the navicular bone, the cuboid bone, and the three cuneiform bones. These bones are connected to the basis of the metatarsal at the front and to the talus. Excuse me?
Just raise the skeleton, please.
Sorry?
Raise it. Raise the skeleton up. Yeah. Now we
Okay.
can see you.
Okay. About the bones we discussed. Yes, the talus, calcaneus, okay, navicular. And here we start connecting with the metatarsals and the calcaneus to the back. So you see, it connects back to the calcaneus. The forefoot comprises of the 5 long bones called metatarsals, as well as the phalanges that form the toes. The first metatarsal, whose extension leads to the big toe, is the shortest and the thickest of the 5 metatarsals, plays an important role in walking. We will be talking a lot about this big toe, and it's really, really important about our stability and about our ability to generate force. Now, near the head of the first metatarsal starts the plantar surface of the sesamoid bones, which are small bony structures like one, over which the muscles of the foot pass and attach. The second, third, the fourth metatarsals are located between the first and the fifth, and they are connected with small intrinsic muscles as well as small tendons that are not really able to stand the big loads. But what we see in nowadays, these metatarsals are not the way it used to be. So everything now feels as if we squeeze them in narrow shoes, and if we let our feet become weak. So this is another option. We can see the back of the foot. We can see the talus right under the tibula and the fibia. So the navicular bone, and then we see the cuboid bone. Actually, it doesn't really look like a cube, but that's how they call it. And then we see the cuneiform bones that attach to the first metatarsals. Then we have the phalanges. As you can see, the big toe has only two, where the rest of our toes have three. Same thing with our hand. Now, these joints are controlled and stabilized by connective tissue and small intrinsic muscles. Of course, everybody knows the ankle joint that helps us go up and down, but we do have the subtatal joint that helps us navigate left and right. Now, the magic part is that we do have 19 muscles, and our brain is able to control and move these muscles. Ideally, we should be able to move and control, but shoes and a sedentary lifestyle, of course, have changed things, and we're trying to reclaim some of this strength back. Now, it's important to understand that we not only have intrinsic muscles inside the foot, we do have more surface muscles, but we do have muscles that come from our leg down to our foot and control the movement for the foot. And so we have plantar flexion, plantar dorsiflexion, and plantar flexion. We have toe extension and toe extension and toe flexion, abduction of the toes and adduction, foot pronation and supination, eversion and eversion. That's another way of seeing the muscles, but we are going to be discussing not just the function of each one of them, but how they are connected and what is their role to prevent injuries and, of course, rehabilitating from injuries. Now, the role of the foot is very basic to our functional capacity. Why? If there is an imbalance, that will travel up to the knees, to the hips, and even up to our shoulders and our cervical spine. So we know if there is an injury in one of our feet, that means that we might even end up with having cervical issues. So we know now that whatever happens in the body travels, and whenever there is an injury, we never only look where it hurts. We know that the reason for this pain is never where it hurts. So if the feet have a problem and it can send messages to the rest of the body, most of the time the problem for the feet comes from the center of the body, maybe from the hips, maybe from the core. So we need to understand the interconnection. Maybe we had an accident and we had a problem with our feet, and that travels up to our hips. For instance, when we have an ankle sprain, we know now that the gluteus muscle gets more inactive. So it's the body's defense to bring the force production down. So every time you have an injury in the lower leg, and that includes the foot too, we should reconnect and retrain the glutes to work back. If a trainer focuses only on the feet, he or she loses the whole point. Our point is to understand the connection. So every time there is an injury in the foot, we should look back to our glutes, because this is what happens. We get more inactive glutes, and then it can travel back anywhere. Another example, when we have an injury in our feet and we have, for instance, an ankle sprain, then maybe our cuffs are tight, and that means our knees are affected. Maybe we need to protect the ankle joint and we tape it. We make things worse. We may avoid to have another injury to our feet, but maybe we cause more trouble to our knees. So we can't just see the foot by itself. We need to understand the whole body and how that works. So for instance, maybe you want to stand up and perform this test for me. So let's perform a toe touch test. So you're standing, you're bending over, you're trying to touch your toes, okay? If you can touch your toes, that's fine. It's normal, no discussion. If you cannot touch your toes and you have some distance, let's try to bend one knee, right? If we bend one knee, maybe in one of the two times, right or left, we get lower. The moment you get lower, you know that this leg has the problem. For instance, if you do this test, and let's say you bend the right knee, no difference. But then when you bend the left knee, you can reach further. That means that the problem is in your left knee, right? Now, where is the problem? It's not in your low back, because the moment you bend the knee, something changed. So the problem is not in your low back. It's either in your biceps femoris, your hamstrings, or your gastrocnemius, right? Because they both connect with the knee joint. Great. Now we know something is happening in our left leg. But when we sit down and we do the sit and reach test, then everything is fine. How can we explain that? We explain it in this way, that the moment we let our feet relax, we had no problem. That means that the problem was in the gastrocnemius muscle, right? So if our flexibility depends on the gastrocnemius muscle, what would you do? Would you stretch the gastrocnemius muscle? Well, this is what has been happening since the old times until now. Now we know that gastrocnemius, it's not tight because we use it a lot. Think, if you have an athlete and he's a runner, he might be getting tight gastrocnemius muscles, yes? Okay. But if it's a person who works in an office, and it's a man, it doesn't wear high heels, it's a person that works in the office and sits all day, why would he get tight gastrocnemius? Now the scientists know why. It's the body's defense to instability. When we are weak, when our hips are weak, our core is weak, the body tenses our feet, our ankles, to stabilize us. So it's not a point of stretching, it's a point of stabilizing the body. So if we tend to think locally, thinking just the feet, we would say, I need to stretch my gastrocnemius, this is why I cannot reach my toes. If we think more globally, we understand that we have tight feet, tight gastrocnemius, because the body needs that stability to feel security. The moment you activate the glutes and you train the whole body, you might have a chance to release some of this tension of the gastrocnemius. So we want to see the whole picture. We don't want to see just the feet. Now, another way to understand what is happening is not just the functional test, but some break tests and physical therapy. It's being used a lot. We use our hand and we test the strength. Maybe there's a big variation, depends who's testing, what's the situation with the client. Maybe you have a good connection with them, so you really encourage them to push a lot, and in another environment they might feel discouraged and they don't push a lot, so you get a different number. But if you keep using that test with the same client, you definitely are getting some results that are reliable. But I have another suggestion. There is a way to test that. We do have monitors that we can use and test that and get specific results. I forgot to have it with me. I actually have it here, but if we have a small break, I can show it. But I can send the link. It's the K-Invent. The company is called K-Invent. So they have small sensors, it's like this big, that you can use, and with an application, it's connected to your phone, your mobile phone, and you get a diagram of how much force you can place on one leg or the other leg, one arm, the other arm. So it's not just a break test. My ability to understand my client's force and judging whether he's strong or not in the right or left side, but having a real number to check. And when I have this diagram and I have the deficit, the percent of deficit, I can email that to my client, or I can put it down and plot a graph so I know where I'm standing today, what are the benefits after 1 month, what did my training do after 3 months, and so on. So that is a good idea of testing and knowing a little bit more than what we used to. So again, encouragement can increase the result up to 20%, and that is important. But remember, that is a benefit. If you can encourage your patient to give you 20% more strength, that means that you can encourage them to become stronger along the way. So that is the sensor I was discussing. For instance, we are testing gastrocnemius, we are testing plantar flexion, and that is a way to activate the person and see how they feel. I could do that with my hand, but this is different. I can place just my big toe on the sensor. What do we expect? We say we have a good strength on our big toe if we can have a force that is equal to 10% of our weight. So if you can press your big toe with a force that is about 10% of your weight, you're doing good. And for the rest of your toes, 2, 3, 4, 5, if you can press the ground or the sensor about 7% of your weight, that it means that you have a strong plantar muscle, so maybe you're in a low risk of plantar fasciitis or nevrosis issues. Another way that we can check is this force plates. Again, they are easy to get around. It's not the big equipment that maybe a laboratory has. I have it in my establishment and I can show them to you. I would recommend that if you want to take one step further and maybe give your clients the chance to do more, that is a good choice. Give me a minute. Okay, so what do? When you step on them, the sensors can check where your center of gravity is. So we can see whether we put more force on our right leg or our left leg. We can check if, let's say, we're doing a squat, how much force we let on the right or the left leg. If we do a jump, if we balance on a balance disc, or maybe do simple exercises like in TRX. Also, we can put them parallel in the other direction, and we can check whether we put more force in the front part of the foot or in the rear part of the foot. Also, as you can check in the diagram here, this is the variability that we check of how much stable we are. So when we're standing, we do little movements we don't even know. We do little movements like maybe balancing out right, left without realizing. We do realize it when we stand on one foot. When we stand on one foot, we definitely understand that maybe we're shaking a little bit. So we can check this variability on our posture. How much do we move? So that means that shows us how stable we are or not. So these are some other ways to test our feet, and then of course test that we can check our flexibility again with some sensors, and we can check dorsiflexion, we can check our big toe movement and version inversion, and get more information. Right? Okay, this is the force plate again. We did that. This is the analysis we discussed. And these kind of results. Then, of course, there are some more field tests that we can check the ankle of the ankle joint and see how much dorsiflexion we do have. So we stand away from the wall, and there are some measures. There are different tests and different tables. You just need to follow the instructions of the test you pick up and use the table that they use to evaluate what is the flexibility in the ankle joint. And practically, this is what will allows us to go down on a full squat. This is what allows us to maybe prevent some injuries if we fall down, and maybe save our knees along the way. Also, there's a functional screening test, the FMS, if you have heard of that. And one of the FMS tests is the ankle mobility screening. And Gray Cook is one of the, let's say, the fathers of functional movement and exercise. So he evaluated that the ankle mobility of 30 degrees and less might be a serious problem for our musculoskeletal health. So there's a special...
Doctor, your round is interesting.
Sorry? Sorry? I did not hear you. I'm sorry, I don't understand. Is everything okay?
Yes, yes, yes.
Sorry, I don't understand. Can you send me a message? I cannot hear you.
You can complete that. You can.
Please send me a message because I cannot hear what you're saying. It does not come out clear, so I don't understand. Everything is
Ma'am,
okay?
everything is okay. Yes, okay.
Okay. Okay.
الدكتور اللي بتسأل بس صوتك مش واضح.
What?
That's not your problem.
Okay, do you want me to continue?
Yeah, doctor, continue.
Then there are tests that I can get a video analysis, and don't think that you have to go and buy special equipment. You can just videotape your patient and then make the video slow and get a screenshot. Then draw lines and you understand what is the angle of each face, for instance, for gait. So you understand what is when they initial contact the floor, what is happening in the stand phase, what is happening in the toe off phase, and you have a feeling of where they're standing today, and maybe you can check them after the rehabilitation process. Again, if we have issues with people that choose to squat even though they don't have the minimum mobility, we can check their ankle today and let them progress in another way. For instance, give them some assistance. But these are field tests you might want to use if you work with athletes. First of all, we need to evaluate walking. Many people don't deal with walking when they work with rehabilitation because we do work in small rooms, we do work with a patient standing or lying down or working out in some exercises we put, and we never see them walking. I think that it should be one of the basic tests we evaluate people when there is an issue with feet and ankle. We need to have them walking towards us, walking away from us, walking from the other, one direction and the other direction, and videotape them. Also, for simple exercises that you don't even think that feet would be an issue, and everybody's thinking quadriceps, glutes, back muscles. If there is an instability in one of the two legs, if one of the two legs have a different arch, let's say one is more flat foot and the other has a high arch, I might distribute the weight in a different in a different way. So that will cause lots of problems in the future as I increase the resistance. So just by looking at exercises when people perform simple free weight exercises, I can evaluate the result because it might not be something you see. Maybe when you check them on a standing platform evaluating feet, you don't see that, and you only see it when you put load. So you don't really know much by just checking on a platform to see the arch. You need to check on walking, you need to check when people have loads on their back. For instance, when we have a person that is a heel dominant, okay, they might choose to do a 30 degrees toe out. If you have a person that is more toes dominant, who would be more toes dominant? A person that has tight calves, right? They will need to get their feet out, and that is not a very good idea. The last 10, 15 years, with CrossFit being so popular world around, people start squatting like this, but this is way off the natural, our natural way of using our body. We would say up to 30 degrees might be acceptable, but we're looking at going maybe 10, 15 degrees out and then have better distribution of the weight. And we are looking putting the weight on our foot with this tripod. So one is at the heel, the other one is at the base of the first metatarsal, and the other one is at the base of the small metatarsal, the fifth. And generally, we should be able to sit before we put weight on it. Many cultures are still using this position as a position that it's a leisure position that we can sit and maybe talk or eat. And this is a natural sitting position. That's why we call it squat. But when people try to load the position that they don't have, then issues start. And if we have a foot issue, it can only aggravate it. It won't show it. Now, there are specific tests that we can do into some exercises to evaluate the position of the foot. And it's not the knee. Many people look at the knees and say, okay, the knee is out of the way. It's not the knee, it's the foot. The knee, we say, it's a joint that does whatever the hip and the foot telling it. So we need to look at what the foot is doing. So if we stand and start a lunge and we see the foot coming on the inside medially, then we start worrying that this foot is collapsing, is going down to pronation more than it should. If that knee goes a little bit on the outside, we feel confident that the foot probably is doing its job. Yes, the foot, it's on its own. The hips will make it better or worse, but we test the exercise and then we need to go back and evaluate where is this coming from. But the foot generally at this position probably is not doing its job. So this is what we're looking at. We're looking at in front. I'm sorry for this Greek. this is some Greek titles. So we're looking at front of this person, and at the same time we go back and check how their foot is looking on the behind part. And problem starts with the shoes, of course, because we used to wear shoes just not to hurt our feet or to keep our feet warm in the cold weather. And then the shoes became a cultural thing where people used shoes for status, but it became just not functional for our foot. We don't need all this cushioning. All this cushioning is letting us run or walk, striking our heel down, and that is not giving us good force absorption from the body. We need to use more the mid-foot strike, and that you understand if you ever try to run barefoot. I'm not saying that it's a good idea for people to start being barefoot all at once, but going back to the natural way of using our feet can have a big impact in understanding how we should be standing, how we should be walking, and how we can protect ourselves. So just by trying to use the midfoot can have an enormous effect on preventing injuries in runners. And these days, we start looking at the foot and the shoes, the athletic shoes, because we ended up wearing high heels. If you look at the shoe that we're using for athletes, we're using shoes with high heels, and that is not natural. We're made being barefoot. We don't need these high heels. I'm going to go back to that in a little bit. So it's funny that we get injured by running when running is such a natural movement, but we get injured by running not because running is bad for us. Running, and there are statistics that show that people that run have much less injuries in general than the people that don't exercise. So it's not the running that it's the problem. It's the way we run, it's what we wear, and it's what we do the rest of our day. So these are some injuries that we could mention when we discuss the foot, and there are maps that can help us evaluate what could it be. Of course, some things are really obvious, some things are really easy to evaluate, but sometimes there might be 2 or 3 or 4, or as you see, much more options of why do we hurt at that point. And same thing goes for the front part of the foot. Same thing goes on the side part of the foot. There's so many different reasons that might hurt a certain point of our foot, and we need some time to evaluate and exclude other situations. When we look at the foot injuries, we first need to look at how is a normal person today? How are we standing? How are we walking? So instead of going one injury at a time, I want to focus what are the reasons, the common reasons that most of those injuries share. So first of all, the way we stand. If you can do it now that we're talking, you can try this. Stand up, close your eyes, march in place, not think too much, just march in place, then stay where you are, open your eyes, and see how you stand. So the first thing, I cannot move, I don't know how you can see, so I'm stay where I am. So stay and look at your feet. Are they parallel or are they turned out? And check one more thing for me. Check your hands. Are your hands next to your hips or are they in front? Because the typical person today would be standing with feet out and hands turned in. So if our feet are turned out, what does that mean? It means that our brain senses instability and spread the base of support. So if this was the area of the base of support, now it's becoming larger. So I have greater stability. So that is one. And if my feet are dropped in, that means again, I pronate because my feet are weak and I let them fall down for better stability. And this, you cannot change it with exercises. If the brain decides to do that, this is a defense mechanism to save our stability. So how can you change it? You will do the exercises, you will do the therapy you want to do, but you need to retrain the body to feel secure. And then the other thing, if your hands are in front of you, that means that your center of gravity is in front. And everybody today has the center of gravity forward. We lean forward. And that is because we spend so much time during the day sitting that our hips are tight and our spine is not strong, our back extensors are not strong, our glutes are not strong. So I lean forward a little bit and then my hands are hanging out in front of me. Having the center of gravity forward is making me more prone to falls. It makes me more prone to issues in the feet. It makes me more vulnerable in my knees, in my hips, in my back, even in my neck. What about these feet? But these feet cannot help me absorb forces. When I lose my natural arch, I have no absorption of the forces. That means that the impact forces from the ground hit me way up to my head without any protection. So these feet, the dark feet, is the beginning of the story. And then when we evaluate somebody from the back, we need to evaluate them in many different conditions, not just by, okay, you stand and I check your feet and then we're fine. No, I have you walk, I have you lunge, I have you squat, I have you do different things and notice what you're doing without you understanding that I'm observing. So I can understand in what position does your feet change its direction or deviates from a standard position. Okay, we said that. And we do help the rest of the body by checking the ankle mobility. First of all, when we have a limited mobility in the ankle, we have pure distribution of stress when landing, as we said before, and there is a correlation with knee injuries. Remember how basketball players used to use really strong, hard leather shoes that they're coming up to their ankles. Now things have changed. They don't use these shoes anymore. Why? Because they notice that the more they stabilize the ankle, the more the knee problems they have. So when we have an issue with the ankle and we don't focus in strengthening it, but we stabilize it with shoes or taping, we cause problems in the knees. And then sometimes we can let our feet, let ourselves without the protection of our foot, and that is a direct cause of low back pain. So they think that if we go back and train the feet, we can help the low back because the foot has the sensors, has the only way that we can absorb force, and has the only way that we can redistribute the forces up in the body. So yes, we're going to strengthen everything, but we need to train how to walk better. So how do we check normal feet and flat feet? We can photograph and draw lines behind, or we can just have a real video of them walking, and that will give us the options of maybe screen save and draw lines. Now, when we see feet pointing outwards, of course we have to check the hips as well, because there might be a lack in internal rotation, and just because the hips have a problem, then the feet are trying to compensate. So sometimes we might need to address the issue above. On the other hand, if both feet are pronated, then we do have an anterior pelvic tilt to compensate for this force production. So always check above and below where the problem is. So when we see somebody letting their knees down, it's not a point of correcting, oh, you should not let the knees go in front of your toes. The thing is to understand, why is this happening? Is it pronation? Is the ankle mobility? Or it's something else like hamstrings, lack of strength, especially in the eccentric force. Other factors that might affect the foot and fatigue the calf and the rest of the foot could be, of course, high heels. We're not made to wear high heels. I don't know how the doctors see in your country, but in my country, there are doctors that are suggesting that women should wear shoes with a little heel, and that the natural thing is for women to wear at least 2 centimeters a heel. That is not true. There is no research in that. Nobody in the world backs up that. Maybe it's a Greek thing. I hope you guys don't do this, but there's no reason to do something like that. Women are the same with men in that, and we don't need heels. We were born without wearing shoes, and the most natural thing is to be barefoot. But when we put shoes to our babies, when they start walking, we destroy their feet since day one. And when we practice and do sports in high heels because Nike or Adidas or Hoka or all the good brands do create sport shoes with heels, then it's not a problem if somebody's wearing high heels. It's an issue that everybody does. Then hard shoes. Many women would say, I don't wear high heels, I'm fine. But they wear this flat, like flat surface, but high elevated shoes that are very hard to move. Men or women, if we wear hard shoes and we cannot move the shoe, the feet, then we're still ruining our feet. Then it's how narrow the foot is. The mid part of the shoe should be wide enough for our foot to stay open as they would if we were barefoot. Then, if we spend a lot of time, of course, standing or wearing special socks or driving, or maybe too much uphill walking, and maybe support on a footrest. Many people, their offices, they tend to put their feet somewhere and they have the feet locked in a specific position. Most of the times, it's something that we do for a long period of time that causes the injury. And it's never one thing. Most of the times, it's our lifestyle in general. So let's say that we have an issue here. So we have a person that has one foot with pronation and the other foot maybe it's a little bit supinated. That will be accompanied with a drop of the navicular bone. Then the right foot that is in supination, it's going to be a little varus, accompanied by a drop in the cuboid bone. So that when you reach up, you will see a deviation in the pelvis. That in the same time might cause knee, hip, low back, and problems even up to the head. And this is proven and this is shown from so many scientists that it's now common sense that if one foot for some reason has some more pronation, it will deviate the whole body, maybe give symptoms like scoliosis. Now, we never really know, is the scoliosis starting from the spine or is it starting from the foot? When we see things happening, most of the time we notice the spine, but we never notice the foot. You don't see many doctors check the children's feet for pronation and supination symmetry. They check if they have flat feet. If they have a minimum normal feet, they wouldn't go into details. And that might be causing, I'm not saying it's a definite, but it might be causing some of the scoliosis we see in an adult life. For instance, when we start assessing somebody and this person is 30 or 40 years old, he already has developed a pattern. Now, can you rehabilitate this person if you don't do something about the pattern? Then you have to plan to see this person in this everyday life. You might need videos of how this person plays tennis or how this person runs. If you cannot go out of your office, if you cannot go out from your environment. If the person does not follow, this is the natural way we touch the ground, right? We start supinating from the heel and then we go towards the big toe pronating. There's no way that I can check that in details unless I'm in a biomechanics laboratory. But still, the more I observe this person and the more I take information from their everyday movements, I can understand more about it. So check the contact phase. Is the heel hitting the floor? Is the heel hitting the floor straight or turned outside. It's the heel hitting the floor and collapsing right away or going smoothly. Now the mid stance, is the mid stance giving a pronation too soon? And that means the arch is not strong, or does it really go with a nice flow? And then the toe off. In the toe off, we read whether there is a mobility in the big toe. If there is no mobility in the big toe, what will happen? Then our hip flexors will be affected, and then even our neck will be affected. Because if I'm not able to bend the big toe, then I need to propel my other foot earlier. That means cause too much more tension for the other leg to reach forward. And then my head also is going forward. So by having a big toe that does not have the mobility, I can affect my hip flexors, I can affect my back, I can affect my cervical area and the position of my head. Now, how about the heel strike? Same thing. If the heel strike if I don't have much dorsiflexion, that means I cannot lift my foot up. That means that the other leg needs to rush. So again, if I don't have the right mobility, I won't have the strength to do the movement in the right way. And another very simple way to do this is to draw a line and have them step on chalk, on some white powder, and let them walk. And you will see the legs straight, whether they're symmetrical. You would see whether they tend to lean on one side, and then of course you will check their arch. Again, we need to check with biomechanics to understand this, but if you know what you're looking for, then you can assess them even by looking them without a specific test. So what is the gait analysis we need to be aware? When we understand the mid stance, it's the gluteus medius because it balances out. If I am not strong in my abductors, then my hip will drop in one side. So this is what I read. If in the mid stance, they have their pelvis on the side. How about the concentric? I lower a little bit. And if I don't use my gluteus maximus, you'll see people walking by throwing their feet in front, like not really smoothly lowering and going, but walking as if they have their feet straight. And there you see it's a dominance in quadriceps. It's like their quadriceps are kicking forward. It's because glutes are not balancing out this concentric form. Then iliopsoas, they have to lift the leg to go forward. Now in old people, we see a hard time in that. And what do they do? If iliopsoas are not strong, I lean forward to counteract that. So we need to train iliopsoas to lift the leg for people to maintain the upright position. It looks the opposite because the iliopsoas will bring us forward, but it's the strength they don't have that gives us the momentum as if we're falling forward. The adductors will control again the side position of the pelvis, and just by living. If I'm not strong, then again I might see a little drop on the other side of the pelvis. Then abductors again control the mid descent, and then Quadriceps will be important for the knee stabilization at the heel strike. And then, of course, hamstrings to be able to control the extension. They are the antagonists. So if they don't work, you'll see a lock in the knee. And then tibialis anterior needs to dorsi to counteract for propelling the foot forward. Right? Of course, gastrocnemius should be able to slow the dorsiflexion rate. Again, I insist in the gait analysis because I think we have neglected, and just because we work in small areas, it's not practical to have people, patients walking up and down and watching them. If there is an issue with getting a video from them, take the video with their own phone so you don't have legal issues. So you take the video with their own phone, have them assess it with you, show them what you're looking at, and hand it back to them, because there might be legal issues of not videotaping anybody. If you feel comfortable doing that, it's better if you videotape it with your own phone so you keep records to compare what you did. Another issue will be the big toe. It looks a little bit like the ankle mobility issues. So if the big toe is not going up, it doesn't let me extend my arch, and also it does not let me have a smooth toe off face. What are the priorities? For me, top priorities for the foot should be mobility and strength of the big toe. Big toe should go up to 30, 45 degrees. 30 is the minimum to have some health, and then you need to work on that to get it up to the 45 degrees. How can we do that? We can use little bands like this and help our toes to come up. Try to lift our big toes up. If we have time by the end, we might show some exercises. And maybe in the beginning we need to assist it, and then eventually load it. Alignment of the big toe. For many women, especially with bunions, the big toe is turned in. We have more adduction towards the other toes, and the abductors are weak. The same muscles that abduct the big toe are the same muscles that we use to press the big toe. So as you're watching now, put your feet down on the ground and press your big toe firmly on the ground. Even if you wear shoes, it works the same way. Press the big toe down. Now palpate your arch. As you're pressing your big toe, palpate your arch and see how strong it becomes just by pressing down. Now, if it tends to move to the side, press it down and try to spread the rest of your toes away. The other way would be to put your toes like this. So let's say these are my big toes. I put a small band. These bands are specifically done for this reason, for the feet. And I have them banded together so they kind of learn to go up and down in line. Or maybe I have a small ball or something in between, so they press to each other and trying to maintain the abduction. Then, stability of the foot. Many people think that they can gain stability just by putting themselves into unstable surfaces. That is not true. To stabilize the foot, we need to load the foot. We need weight. We need to do single leg movements, single leg stands. And we need to train us to stand into different surfaces. That means unstable surfaces. This is, I don't know if you can see it, this is the blackboard. I don't know if you are aware, if you know this thing. What do is we put our feet here and try to balance. So this can move. I can have it here, or I can have it on one side and stabilize the side I need to do. But first we start on a stable surface and put load on our feet. Then we discuss about unstable surfaces. For instance, this is another one. It has a nice surface that gives some activation for our nerves. And again, here, these can be moved to put them where I need them to be to give me some challenge, but according to my level to go progress smoothly. So balance between pronation and supination, we should be able to balance with our feet supinated, we should be able to balance with our feet pronated, we should be able to balance on a surface that is downhill, like one leg supinated and the other pronated, and we need to play with that. Then, mobility in the ankle, especially in the sagittal plane. We need to balance the gait and running rhythm from supination to pronation, and then the foot alignment to optimize the Achilles tendon and ankle movement. So first of all is the release of possible tension in the ankle by working the hips first, by stabilizing the rest of the body first, then working on stretches. The stretches are not really the solution because stretching, static stretching especially, does not train the brain. You need mobility exercise that is active movement of the body, so the body understands how to go there with safety. If I just stretch passively, I don't help the brain get to that position. It might feel good through my session, but then the patient leaves without real results. We need to train their brain. So there is a list now that connects different issues with different injuries, body injuries with different issues of the body. This is a table that is according to the common problems that a human body faces today. And so I made this connection that shows us how important different parts of the body injuries can link to different issues that we might have around our body. Now, the management way to do it is, first of all, I would say not mobility, release. So release can be done with other methods or equipment that we might have in the physical therapy place, and it can progress to the active training of the brain. Then we build static stability, then we work on dynamic stability, then we integrate the movement together, and then we discuss about locomotion, that is building the strength or the power or going towards the performance. But first comes release of the tension and mobility. You cannot progress with strength until you prepare the part with mobility or stability. So equipment I would use, myofascial release equipment like this, and again, I am talking about equipment away from different machines that you might be using in physical therapy. I'm discussing about functional rehabilitation with real life help. So first, we might want to release our feet with things like that. These things can go to, these are black rolls, very famous German Swiss company that produces things like that. And they created a small roll that can be put in the freezer, and you can have it like cold and use it maybe for plantar fasciitis to help them relieve some of the pain. These balls can be too rough for people that already have plantar fasciitis, so there are options like these balls. These are softer balls, and you can actually step on them and release your feet and extend the small muscles between the metatarsal and phalanges. Then blackboard is this one. Beams. What are the beams? Beams are like the branches of the trees that we used to walk when we were still in the mountains, in the forests, and we need to train our feet to be able to walk in narrow surfaces and be able to grip with our feet. So learning to walk on beams might be like a challenge for more advanced people, not in the beginning. Bosus and small alternatives like this are also very good. And I am not a fan of balance disc. I'm not fan of the hard balance disc. I do prefer these ones that are soft, do have some activation little features here, and you can stand on them, you can practice different things, and a patient can buy this and have it at home and practice all day. Now, IREX is a company that made these foam platforms that you can play. Naboso is the ball that has this surface. And again, you can use it to help a patient with neurological issues also to feel more. Now, a towel. How can we use a towel? We have the towel on the floor and we learn to play walk with our feet, maybe drag the towel with our toes and strengthen the toes. These are some of the very classical issues that mid-age people will face. With increased body mass index, like the weight, most of the people increase as they age. We tend to have less and less ankle and big toe dorsiflexion, so we lose our mobility, the big toe and the ankle. We lose foot and hip strength, and maybe we decide to increase the activity all at once. So this is a very common model of problems that most of the times will be sensed in the heel. What we need to do is start working with our feet. The more, the better. The more time we can spend without wearing shoes, the better. Get the information in the brain, start activating the brain, then give them commands. If you have a person that lives with their shoes all day, staying still all day, and you just do some physical therapy and some exercises, the results won't be astonishing. But if you teach them to spend more time at home, give them some toys to play at home, or if they have a choice, go out and maybe step on the sand or step on natural ground, then you will have so much better results. We discussed the effects of the injuries of the feet to different other places of the body. So the importance is huge. And now I have the list of all the injuries, but I am afraid that we won't be able to. I'd like to discuss a little bit about plantar fasciitis because I don't know about you, but in my country, it's huge. It's like everybody has it once in their lives. And it's not just in athletes, it's most of the people that try to do a little bit more, or maybe they forget how to protect their feet, so they suddenly wear bad shoes, get tired with something, but it's not just one reason. It's the weight, it's being out of shape, it's having weak feet, is trying to do more, is working on bad surfaces, and is protecting my feet so much with cushioning shoes. And suddenly, if I stand on something without my protection, then I really get the aggravation. Um, of course, there are many things we can do, and it's not just the feet. First of all, it is linked to the glutes again. So we need to strengthen the whole body. We need to check whether there is hyperpronation, but the truth is that it's not happening only in hyperpronate people. It's happening also to people that have high arches, also to people that have hypermobile bodies. So it can be with shortening muscles and pronation, and it can be with supination and high arches and too loose joints. So we need to normalize the foot as a first goal. And then at the first period, we need to protect. Yes, we cannot go barefoot. We cannot use things like that. It's going to aggravate it. We need to get the inflammation down. Now, if there are other issues, I can work on the other issues. While I do small things with my foot, I can help with the rest of the body. Usually it's very close to the heel, and sometimes it can be many different other things happening at the same time. But sometimes it can be muscle insertions that can be inflamed. But when you see pain in these areas, most of the times it has to do with plantar fasciitis. Now, it can be a heel spar in the same time, and the doctor will always check for that, but it can happen without it. So if there is a heel spar, it makes things hard, and it's really difficult to get rid or work on that area without spending really a lot of money, a lot of time, and you
شباب، هي الدكتور فصلت فجأة. أيوة، بتواصل معاها دلوقتي. Sorry, doctor, for this. The mic is off, doctor.
Okay. Yeah, can you hear me now?
Yeah, I can. I'm very
Okay.
sorry for this, doctor.
That's okay. Now, now can you see it?
Yeah, doctor, I can see.
Okay. Okay, I kind of went down so we can um, put together and come to the end. Um, okay, I need to remind that we need to strengthen the arts, we need to put load, and we need to take care of the strength, first of all, before we put our feet in instability. And yes, it's good to go barefoot, but wearing flip-flops, it's not going to help us, because you see the way I'm tensing here in order not to fall, not to let my flip-flops fall. I make it even worse for my feet and cause more closed toes. And then we don't need insoles. I know many people suggest insoles, but this is what it is. We need the insoles just for a very, very limited time. Many people, just because they feel that they need the protection, they wear it all their lives. No, we need to strengthen their feet after we use the insoles, and the goal is to get rid of them after a while. So this is what feet look today, and this is how the natural shoes are in order to go back to gain natural feet. And yes, we can get the test and they can suggest insoles, but um, what we're looking is the balance. And wearing an insole that throws our leg on one side does not connect it to our brain, does not give us the message to correct ourselves. I want to go back to, sorry, some of the exercises and finish with that. Okay, this is the towel we're discussing. First of all is pulling the towel. Then it's really standing up and pulling, bringing the towel towards us. Then another exercise is put some weight on the towel and with your foot hold the towel and push it away, or hold the towel and push it towards you. But if you only work with the towel and you have a tendency to get closed feet like that, that will make it worse. So you need this other exercise that we keep our toes straight and we press them down on the ground. Then we need to strengthen with bands, not just the foot, but each toe separately also, and work on different directions, work on different directions. And before we finish, I'd like to remind you that bracing any part of the body, it's not permanent. As you would never use this for all your life, you would never use a belt all your life. We should not use orthotics all our lives. Um, and as fish rarely need any help, or they never get injured during swimming, or birds never get any problem from flying, we should not need anything to run. We did something really wrong there with our shoes. We're not meant to walk on ramps. This is not natural, and Thank you for your attention. Now, um, I don't know how the group feels or if you want to see some of the basic exercises. We discussed about many of them, but if you want, we can put them in some order and maybe you can stand up where you are and try. I understand it's very late though, and if it's too much, I would like to summarize it with this list. First of all, take the shoes off, take the socks off. Socks are also bad. They keep the feet like this. You need to spread the toes. So spread the toes as much as you can, like really open them. Then try to lift just the big toe and put it down. Again, try to lift just the big toe and put it down. Now, lift the rest, four of them, and put them down. And do this exercise maybe 5, 10 times, like big toe, the rest of them. Big toe, rest of them. You might not be able to do it at the beginning. Hold them until you can. Then press your feet down. If you're standing, as you press your feet down, you will feel the connection with the glutes. So the more you press your feet down, even if you sit, you can feel that. You feel the glutes. Yes? Now, the more you press your big toe down, you feel your arch. And we need to train this arch to be strong. So try to press your toes down without getting them like that. Right? Then try to come up like you're going high heels and walk around the room by going high heels. Get familiar with that. Then step on a pillow and play with your feet going up and down, stretching the calves and lifting up on your toes. Then when you're warmed up, you can try to play out and in and out and in. Now, if you need some strengthening, you might want to use one of those and put it like this. I don't know if you can see it. And okay, I'll do it in my hand to make sure I can see. So you put it in your big toe and then you take it around to your heel. So from your heel, you connect this and you have some resistance for your toe. And you do
But
that
actually,
for your,
we can't
sorry,
see your hand.
you can see my hand. Okay. Let's say this is my big toe. Okay. I put it on my big toe and then I wrap it around on my heel. So this is in my heel, the here. And my big toe has some resistance. So I put it up and down. This is still in my heel there, so I can strengthen my big toe. And you can do the same thing with your pinky toe, with your small. So you do the same thing from the other side, because the small toe also has issues and comes along adducted with the rest of them. Then I can use this to strengthen my toe. Like play with that. I can put them together, or I put it like this and I press my toes down. I come up and down and make sure this does not slide. That means I can press really hard. I know it's not that easy because I cannot see you guys. I don't see how you can see me or not. Let's stop here. I'll be happy to answer any questions if you have, or you can send me mails if you need some assistance in something. And I really thank you for this invitation, and I wish you all the best and all this effort.
Doctor, we just want to express
For
our
what?
thanks at the conclusion of presentation for your time and the important knowledge you shared with us today. Thank you, Doctor.
Okay, I would like to take a picture of this. I cannot see
Okay,
you.
I'll
Ah,
send it. I'll send it to you on WhatsApp.
great. Um, I was happy to participate. I wish you a good night, and you did a great job. Thank you.
Thank you, Doctor.